Well, I'm so thrilled to be here today, and as Dr. Meckler said, I think the Browns made another really bad decision for us. So it's nice to be in Louisville where I can see all the fancy dresses and hear about the Derby instead of thinking about what's happening in Cleveland. But in all seriousness, I'm here today because my passion is about giving information about the prevalence of emotional needs, mental health disorders, and helping us to figure out how to incorporate this into our practice. So what I'd like to do today is I'd like for you to look at this patient of yours, and I'd like for you to shout out some adjectives that you may have about this patient. This is a patient you treat. Tell me something about them. Angry. Stress. Strong. Crying. Happy. Energetic. Okay? Right. So when we think about our patients, we think about them more in terms of who they are as people rather than what their disease is. When I treat my patients, I look at all of these symptoms. So I refer to them as the invisible symptoms. So these are things that are not necessarily readily available to the human eye. It doesn't come with a cast. It doesn't come with crutches or a wheelchair. This is something that comes to our patients through way of evaluation, and some of this is through way of mental health. So let's talk about chronic disease in general. So what we know about chronic disease is it's amongst one of the most common and costly conditions in the United States. 50% of all of adults have at least one chronic disease, and 30% of 18 to 44-year-olds have a chronic disease as well. 1 in 4 adults have 2 or more, and 7 of the top 10 causes of death are chronic disease. Overall, cost estimates are $2.5 trillion annually, and specifically with cardiovascular disease, it's $316 billion. And so I think it's important for us to start focusing on wellness and preventative medicine. My goal today is to talk with you about the mental health risks associated with your chronic diseases. And so what we know about depression is that it's a highly prevalent condition in neurological disorders and in all chronic diseases. It is a significant risk to the way that we look at morbidity issues. It decreases our quality of life. It leads to disability, and we think about that because many times people are very dismotivated, and so therefore they do not follow through on their treatment regimens. They have apathy in treatment decisions. It just doesn't matter to them. Again, that motivation issue. It certainly affects more than just the individual with the depression. It affects the whole family dynamic, and it can also lead, unfortunately, to suicide. So when we look at some of the prevalent statistics of the neurological conditions, first, let's start with the general population. Prevalence rates suggest that in the general population, depression occurs in about 2 to 6% of that population. In post-stroke, we're noticing that it's up to 61%. In Parkinson's, up to 45%, Huntington's 30%, dementia 30%, epilepsy 30%, and in the specialty that I practice in, multiple sclerosis, we see about 54% of our patients, so 1 in every 2 patients has a depression, and anxiety disorders are about 36%. So because I focus on multiple sclerosis, what I'd like to do is give you the prevalence statistics of MS. So the left-hand column for you in the red are the prevalence statistics for our MS patients as compared to the general population. And so studies that I've seen go up to as high as 54% of our patients with MS have a depression. Anxiety disorder is a little bit more difficult to measure because we don't know sometimes if the patient is talking about a state or a trait. So a state meaning how they're feeling in the moment, or a trait meaning a more long-term anxiety. So I've seen statistics as high as 90%, but the realistic statistic is 36%. Adjustment disorder, which is something we'll talk about in a few moments, is up to 22%. Bipolar disorder, 13%, and psychotic disorder, 3%. So why is this important for us to recognize this and treat it? Well, what we see with the family members is that there can be some role reversal and identity shifts. And what that means specifically is that a spouse that was one time working is now staying at home. One that was staying at home is now working. A child is now becoming a caregiver instead of a child. We also see much emotional reaction. So this looks everything from grief to actual depression, anxiety, worry. We think about the grief and acceptance model when we're thinking about the emotional reactions. There's denial, there's challenges about who do we tell about that we have this chronic condition. So if I tell my job, will they fire me? Will they let me go? If I tell a new spouse or a new partner or a new friend even that I have a chronic disease, what will they think of me? And so there are all of these challenges of who do I talk to about this? And then the invisible symptoms is something that I work specifically with. So those are the "but you look so good" symptoms. You look so good, why can't you go on this hike with me? Or, but you look so good, why are you so fatigued that you can't go out with me tonight? But you look so good, why aren't you working? And those are very, very significant challenges for our patients. So let me tell you a little story. So I'd like to share the parable of the blind man and the elephant so that we can think about collaborative medicine as we move into our next section. And in this story, there is a group of blind men from Indonesia, and they heard this strange animal. They called it an elephant. It had been brought to town, but none of them were aware of its shape and form. Out of curiosity, they said, "We must inspect and know what this animal is by touch." So they sought it out, and when they found it, they groped the animal. In the case of the first persons whose hand landed on the trunk, they said, "This is like a thick snake." For another whose hand reached its ear, it seemed like kind of a fan. And for the next whose hand was on its leg, the elephant was described as a pillar of a tree trunk. The blind man who placed his hand on the side said the elephant is a wall. And another who felt its tail described it as a rope. The last felt its tusk and said that this elephant is hard and smooth, much like a spear. The 6 men fell into a great argument about the nature of the elephant, that they each called each other crazy because of what they had held true of the elephant in their own hands. But no one really understood the elephant. They began to argue about the elephant, and every one of them insisted that he was right. It looked like they were getting agitated. A wise man was passing by, and he said, "What's the matter?" And they said, "We cannot agree to what the elephant is." Each one of them told that what he thought the elephant was like, and the wise man calmly explained, "All of you are right. The reason every one of you is telling something differently is because you touched a different part of the animal. So actually, if you look at the elephant as a whole, it has all of the features that you all said." And so I love this as we think about interdisciplinary care, because the moral is that as we move forward in interdisciplinary medicine, which is where our field should be, we need to value everyone's perspective. We need to hold on what we believe true to ourselves and be able to communicate that to the next person who is evaluating the patient. So nursing, primary care, emergency room, neurology, speech, language, these are all important parts of the medical picture, and you've each touched a different part of the human body. And so it's important for us to convey this to all of the providers that we share the patient with. So what specifically does it look like in Mellon Center, where I'm from? Well, our interdisciplinary team, so the Mellon Center treats multiple sclerosis patients, and our interdisciplinary team looks like medicine and nursing, and we combine that with physical medicine and rehab, and so that's everything from our PM&R docs to our PTs, OTs, speech and language, cognitive therapy. We have a clinical research team, and then we have a behavioral medicine team. And all of us work very cohesively together. We're able to walk downstairs to one another's office or upstairs and talk about a patient that we may be collaborating on. So I love this cartoon because I oftentimes get asked, so why is it that somebody would send somebody to a behavioral medicine specialist? And what this shows is the neurologist saying to the patient, whoa, that's way too much information. And so they end up sending to me. But in all actuality, sometimes it occurs that way. But sometimes it actually occurs by way of self-report or self-referral, by way of physician's report, or at the Cleveland Clinic, we have a wonderful online system in our electronic medical record where patients can take this evaluation before they come into our office visit. And every patient takes what's called the Knowledge Project. And in the Knowledge Project, we have a PHQ-9, which we'll talk about here in a few minutes. And so the patient is able to take that on the little iPad device at the office or in their own home. It's on a tablet. It goes to our secure wireless system, and then it populates into the physician's desk. And so what this encompasses is, of course, the self-assessment. The MSPT is the MS PASS, which is something that we're working on at the Cleveland Clinic with 10 other institutions. And it's incorporating some real live data in our patients' medical charts. The KP for neurology has the PROMIS, the PHQ-9, and the MS Experience Survey. So that's what our neurologists give the patients. And then when they see me, they take the PROMIS, the PHQ-9, the MDQ, the CAGE, the G87, and the PDI. And I wanted to show you a little bit about how this populates into our note. So this is the MSPT, and so I love the PROMIS on here where we're able to look at the heat maps, specifically the social and the mental activity of the patient. So it shows you, worst case to best case. With the KP, and with the MSPT, all of our patients are taking the PHQ-9, as I had shared with you. And so a patient will complete this, and every 28 days they'll complete this from there on in all of their appointments at the Mellon Center. And so an alert banner fires if the PHQ-9 is at or greater than 15, which is the moderate to severe level. And when this alert banner fires, it tells us about a best practice that we use. And it generates a consult immediately to behavioral medicine. And it's a very easy and seamless way for our neurology team, our physical therapists, our nurses to be able to send somebody to us. And so this is what it looks like on their screen. It's bright yellow. They are really unable to get out of that screen unless they click the consult. So they either have to accept or decline that consult. What I love about this is we can then graph out how a patient is doing over time. So this is a person who had a depression that had been elevated, it had come down, and then it was starting to elevate again, and so we wanted to see them again in behavioral medicine. And so this tracks for all of our questionnaires, and we're able to show this to our patients to show them their progress. So I'd like to speak specifically about what behavioral medicine provides to an interdisciplinary team. So behavioral medicine could be psychology, psychiatry, social work, counselors, nurses. It could be a whole host of individuals. But what we provide is patient care. We provide consultation, training in my case, and research. And so I wanted to share with you what the two models of patient care in our world look like. So the first is the consultative model. So at the Cleveland Clinic, we have about 30% of our patients who come from all over the country, even the world. And so in those cases, we do what's called a consultative model. So we will evaluate, we'll go right into the neurology office. If there's suicidality or, very rarely homicidality, only once in my 10-year career. But if something like that is to occur, we go immediately downstairs. We meet with the person right away. If they're an out-of-town person, we become part of their treatment team by way of consulting and developing a treatment plan, and then we help to connect them to somebody in their part of the country. In terms of treatment, which is the other 70% of our patient population, treatment is, we evaluate the patient, but we treat all the individual, we treat the family members and couples, and we also do group therapy. And then of course we communicate this to the providers. So oftentimes I give a talk similar, and people are in the audience saying, well, that's a very idealistic world that you live in, and it's really wonderful that you come from the Mellon Center, but what in the world can I do about it in my clinic? And so I wanted to give you 4 slides right now that will help you to see how treating behavioral medicine helps the patient's quality of life, but also their financials, and also how, if we treat the behavioral medicine, how cheap it is to put somebody in your center, essentially. So I'm going to start with the first study that I came across in the primary care setting. And this is a very well-known study. This was a study that looked at 1,000 patients from Brooke Army Medical Center, and they looked at evidence for 14 common symptoms. So in primary care, you see chest pain, fatigue, dizziness, headache, edema, the list goes on and on. 62% had no significant symptoms, though they complained of chronic problems. 74% of the cases had no cause of symptom found. And only 16% of the symptoms were due to the abnormality of a body organ. So what this showed was that the majority of the visits in the PC were related to behavioral health needs, but not identified as mental health disorders. So specifically looking at depression, we know that 75% of patients with depression present physical complaints as the reason that they seek care. And specifically, most people who would benefit from behavioral health services to relieve these symptoms rarely think that behavioral medicine is what they need. And that those diagnosed with depression have about 2 times the healthcare costs as those without. So depression is about a $216 billion industry, and it's largely untreated. So let's talk specifically about the numbers here. In a review of 91 studies that found that patients actively involved in behavioral health treatment reduced their overall medical costs by 17%, whereas those not participating increased their costs by 12%, and that's from SAMHSA. The more targeted the behavioral medicine intervention, the more medical savings, and thus the need for specialists in disease centers. So we're going to talk specifically about a targeted treatment within the MS population here in a few minutes, but I just want you to keep this in mind, that we need to target your mental health treatments. And finally, the Kaiser cost savings study, which is probably the most famous, it showed that people who received psychotherapy showed a 77% decrease in average length of hospital stay, a 66% decrease in frequency of hospitalizations, 48% decrease in number of physician office visits, so that may be incentive enough, 45% decrease in ER visits, and a 31% decrease in phone and medical records. So in addition to my role as a behavioral medicine expert at Mellon Center, I also lead the physician engagement team at the Neurological Institute at Cleveland Clinic. And so by looking at our Press-Ganey scores, we were able to do a simple statistic. We looked specifically at the centers that had the most engagement and compared them to the least engagement. And what we found were the centers that were the most engaged had a behavioral medicine provider in their section. Now, again, behavioral medicine can be everything from a psychiatrist to a social worker, but it helps the provider's mental health as well. So what is it that we treat in behavioral medicine? And so we're going to talk about kind of our trio here. Let's start with adjustment disorder. So adjustment disorder is simply a reaction to a major stressor, a new diagnosis in this case. It's very hard to get prevalence statistics on adjustment disorder simply because people are underreporting, people don't know if this is common. This is a common reaction to the way that they are feeling to a new diagnosis. But what we know, best estimates, is that it occurs in 21 to 37%. So again, very difficult to get clear statistics. Essentially what adjustment disorder is it's the development of anxious or depressed symptoms in response to medical symptoms or a disease that occurs within a 3-month period. It's characterized by marked distress and significant impairment in social and occupational functioning, and the treatment is normalizing, empathizing, education, stress management, medication, and time. So I saw a patient just this week who was newly diagnosed, two weeks into her diagnosis, experiencing all of these symptoms, and I told her at the end of the session, we're going to treat her in the next 3 months for sure. But I told her at the end of 3 months, my bet is that she will be feeling a whole lot better, and I can better that because I have the outcomes to prove that. So the one that I focus the most on in my practice is the stress management. And so you all are medical providers, and so I don't need to remind you how important it is to manage your sympathetic nervous system response. But I love this slide, and if you want to take a picture of it, feel free to take a picture of it, because it shows our patients how important it is to manage our sympathetic nervous system response, so our fight or flight response. And what happens to our body when our sympathetic nervous system is on overload is that we have mood issues, we have cardiac issues, we have immune system related issues, we have stomach, GI issues, sexual issues, we have bone and aches and pains in our joints. And so this is just a really important slide that I like to give to my patients in one of our first sessions so that they recognize how important it is to manage their fight or flight or sympathetic nervous system response. And so what I'd like to do now is show you a quick video, and I hope that this is cued. So this is Robert Sapolsky, who is a neuroendocrinologist at Stanford University, if I'm able to get this up. Is there an AV person back there who can help me? Okay. So Robert Sapolsky is a neuroendocrinologist at Stanford University, and he studies stress in both humans and in animals in the Savannah Desert. And so this is a quick clip which is going to come up.
This program is brought to you by Stanford University. Please visit us at stanford.edu.
If you're a normal mammal, what stress is about is 3 minutes of screaming terror on the savannah, after which it's either over with or you're over with.
Over the last 3 decades, Stanford University neurobiologist Robert Sapolsky has been advancing our understanding of stress, how it impacts our bodies, and how our social standing can make us more or less susceptible.
Is the aggregate bad news and
Most of the time, you can find him teaching and researching in the high-achieving, high-stressed world of brain science.
This week's paper is this huge contrast between classical.
But that's only part of his story. For a few weeks every year or so, Sapolsky shifts his lab to a place more than 9,000 miles away, on the plains of the Masai Mara Reserve in Kenya, East Africa.
You live in a place like this, you're a baboon, and you only have to spend about 3 hours a day getting your calories. And if you only have to work 3 hours a day, you got 9 hours of free time every day to devote to making somebody else just miserable. They're not being stressed by lions chasing them all the time. They're being stressed by each other. They're being stressed by social and psychological tumult invented by their own species. They're a perfect model for westernized stress-related disease. Because what stress is about is somebody is very intent on eating you, or you are very intent on eating somebody, and there's an immediate crisis going on.
When you run for your life, basics are all that matter. Lungs work overtime to pump mammoth quantities of oxygen into the bloodstream. The heart races to pump that oxygen throughout the body, so muscles respond instantly.
You need your blood pressure up to deliver that energy. You need to turn off anything that's not essential. Growth, reproduction, you're running for your life. This is no time to ovulate, tissue repair, all that sort of thing. Do it later if there is a later.
When the zebra escapes, its stress response shuts down. But human beings can't seem to find their off switch.
We turn on the exact same stress response for purely psychological states, thinking about the ozone layer, the taxes coming up, mortality, 30-year mortgages. We turn on the same stress response, and the key difference there is we're not doing it for a real physiological reason, and we're doing it nonstop. After a while, the stress response is more damaging than the stressor itself, because the stressor is some psychological nonsense that you're falling for. No zebra on earth running for its life would understand why fear of speaking in public would cause you to secrete the same hormones that it's doing at that point to save its life. I'm studying stress for 30 years now, and I even tell people how they should live differently. So presumably I should have incorporated all of this, and the reality is, like, I'm unbelievably stressed and type A and poorly coping, and like, why else would I study this stuff 80 hours a week? No doubt everything I advise is going to lose all its credibility if I keel over dead from a heart attack in my early 50s. Nah, I'm not good at dealing with stress. You know, one thing that works to my advantage is I love my work and I love every aspect of it, so that's good. But nonetheless, this is pretty clearly a different place than the savannah in East Africa. You know, you can do science here that's very different and more interesting in some ways. You can have hot showers on a more regular basis. It's a more interesting, varied world in lots of ways, but you know, there's a lot out there that you sure miss.
So I love Robert Sapolsky. He writes a book called Why Zebras Don't Get Ulcers. And in that book, he talks a lot about, you know, what he just spoke about there, but how important it is that we manage our own stress and that we teach our patients how to manage their own stress. I'm sorry, this went back to, okay. So I wanted to share with you some studies that I know of in the MS literature. So there are many studies on, you know, class 3 reports, self-reports. So Charcot, who many of you recognize, is known as the first neurologist who was able to link stress to MS. And so he was kind of the first person that brought to light that there was a link between stress and the development of the disease. And then in, I think, 2006, there was the Lebanese-Israeli war. And what they found, again, the self-reports, but they found that there were more MS attacks during the wartime process than there were after. Vietnam vets are another population who are highly susceptible to developing MS. Recently, there's been one class 1 study by David Moore and his colleagues out at Northwestern, and it was published in Neurology. And I want to talk a little bit about this study. So in his study, he looked at 121 MS patients, randomly assigned them to treatment or control group. In the treatment group, they had 16 50-minute individual sessions over 24 weeks, plus a follow-up at 6 months. His measures included MRI with GAD and T2 brain lesions. So keys to his study was that individuals that participated in these stress management groups that did therapy helped them to better estimate the potential impact of a perceived threat and gave them skills to better manage the threat. And when stress couldn't be avoided, he taught them meditation and relaxation strategies to calm their physiological response. And then I find this incredibly helpful in terms of working with my patients, but for an event or a situation to be stressful, it must present as 2 factors. It has to feel like a threat to something they highly value, right? So your health, your functioning, your family, and they must believe that they don't have any control over the situation, which many of our MS patients or chronic disease patients have. So the results of the study, I think, were just phenomenal. So the stress management group had decreases in brain lesion in the MS patients. 77% had fewer GAD-enhancing lesions compared to the 55% of the control, and 70% were free of T2 lesions versus 43% of the control. The key here, though, was that after therapy was completed, new lesions were detected. And so in my practice, what we've done is we realize that our patients are likely in the prime of their life. Our patients are 30s, 40s, 50-year-old individuals. They have families, they have jobs, and so we wanted to cut down the 16 sessions. And so what we did is we created a 4-session stress management protocol. In this, what we do is we teach education, we teach cognitive behavioral therapy skills, and breathing skills. We see ourselves as short-term treatment. We think that we know that our patients, based on our outcomes, get better after 3 sessions, and so we kind of encourage our patients to just follow through on those sessions, and then we see ourselves as a long-term care partner in their lives because we see them afterwards every year, just like a general physician would see their patients. So the third part of what we do in my practice is depression. And so what I'd like to do is walk you through a patient of mine. So this is Elaine. She's a 37-year-old woman with relapsing remitting MS diagnosed 10 years ago. She was referred for fatigue and tearful mood, describes herself as depressed and always exhausted. She describes little enjoyment in her activities. She has functional impairment that impacts her ability to care for her children. She sleeps up to 16 hours a day. Her appetite's okay, no change. She has children, a spouse, and a family member to help her with her daily chores. She's frustrated by her physical limitations and need for family help. She has feelings of guilt for being a burden and not doing for others. She has passive death wishes, no intent or plan, and these feelings have been present for 5 years. So what is depression? Well, depression certainly differs from normal grieving. In my population, the key that I hear is that it's more irritability than it is more sadness, tearfulness. So I'll have significant others saying it's like I'm walking around on eggshells in front of my partner. It's very stressful for family members. It's more common in females than it is in males, but the strength is greater than males. Stressful life events are a strong predictor for developing depression. And of course, individuals with chronic disease are at great risk. So we had talked about the prevalence statistics earlier, that it's about 3 to 4 times as high as the general population in the MS population. And staggeringly, the suicide statistic is that it's 7.5 times as high as the general population. So I think that that's something really important for you to keep in your mind when you're seeing these patients. Major depressive disorder has to have at least 5 or more of the following nearly every day for at least 2 weeks, and it must have sadness, irritability, loss of interest, as well as many of the other symptoms. So with Elaine, she had depressed mood, anhedonia, guilt, fatigue or loss of energy, sleep disturbance, insomnia, and passive suicidal ideation. Now, what's difficult is that many of these symptoms are also the physical symptoms of the disease process. So how do we treat depression? Well, the first line is an SSRI, and this is something that works very well on our patient population. It does take, in some of them, 6 to 8 weeks to reach therapeutic dose, and there are some side effects that we must convey to the patient population. The SNRIs are also very nice because they work on both serotonin and norepinephrine, so that can help with depression, anxiety, and pain. And of course, there are their own series of side effects. From a therapy standpoint, there are so many ways that we can work with patients, and it's not a one-size-fits-all. So I wanted to share a little bit about what we do. So from a psychosocial standpoint, we use cognitive behavioral therapy, which is basically restructuring one's thoughts to improve their moods. So having somebody tell you what their greatest fear is and then help them work on that restructuring. We use the grief and acceptance model, eventually moving towards adaptation. But this is the Kubler-Ross version of death and dying, which many of you learned about in school. But our goal is to help the patient move through the denial, the depression, so that they can make quick treatment decisions. We also make use of community supports. So I'd like to share with you how I teach my patients, because many times patients come to me and say, so are you telling me this is all in my head? And so let's talk about the mind-body connection. So I want you guys to pretend that prior to coming here today, I went to Bed Bath & Beyond and I got a very nice cutting board with some sharp knives, and I have lemons in front of me. And I'm slicing the lemons, and I would like to give each of you a piece of my lemon. And what I'd like for you to do is put that lemon in your mouth and bite down on it. Okay? All right, next, we all get Amazon Prime, so there's lots of styrofoam in your Amazon Prime boxes. There's styrofoam cups. What I'd like for you to do is take a piece of styrofoam and put it in the back of your mouth and just bite down on it. What happens? It's hurting my jaw. Okay, what if I had really sharp fingernails and this was my chalkboard behind me and I just scraped my fingers down the back of the chalkboard, right? So my point in doing that is I saw a lot of grimacing faces out there. The point in sharing that is that the mind and the body are so closely tied because, in fact, there was no physical stimuli in front of you, but you all had a physiological response, correct? And so I do this with my students, with my patients, because I think it's so important for us to share how closely tied the mind and the body are. And so what I'd like to do now is share with you some skills practice, and if you're willing to work with me, I'm going to do an experiment on you. And so what I'd like for you to do is for the next minute, I have my phone up here so that I can time you guys, I'm going to ask you just to breathe. And all I want you to do is try to breathe slowly and count your breath and then report back to me how many breaths per minute you had. So go ahead and breathe. The other room and try to be as honest as you can, thought, my gosh, that was the longest 1 minute of my life. You're thinking, I need to go to Target after this, when is this going to be done? Yeah? And how many of you thought this was really relaxing and really nice to care for yourself? Wonderful. Okay. Okay, so how many of you, just by show of hands, 16 to 20 breaths per minute or more than 20 breaths per minute? Okay. How many 14 to 16? Okay. 12 to 14. Okay, 10 to 12? Okay, 6 to 10? How many under 6? Okay, only a few of you under 6. So 6 is the key number that we want to get to. And I'm going to share this with you. So bad news and good news, I'm going to teach you how to get to 6 breaths per minute. But breathing more than the medical norm at rest, which is about 12 breaths per minute, is considered hyperventilation. And what does hyperventilation do to us? Well, again, remember what Robert Sapolsky was talking about in the video about the sympathetic nervous system. Remember what that picture was that I showed you? When the sympathetic nervous system is on, we're doing damage to our body. So when we look at this PET scan over here, we recognize that our body is starving of oxygen. So when we see normal breathing, the brain is very oxygenated. When we see a hyperventilation occurring, the brain is lacking oxygen and therefore cognitive issues, just as we had heard about earlier. It also reduces oxygenation to all of the vital organs in the body. So one of the things that I teach my patients is about diaphragmatic breathing. So the diaphragm is that little green line that you see underneath the lungs. It's this U shape under the lungs. And the great thing about that is you pull your breath from your chest into the diaphragm and it starts to oxygenate all of the vital organs in your body. benefits of diaphragmatic breathing are vast. They include venous return to the heart and improves. It leads to improved stamina in both disease and athletic activity. It improves the flow of blood and lymph, helps prevent infection of the lung and other tissues. Of course, it increases oxygenation, and it's just an excellent tool to stimulate relaxation. So this is how I'm going to teach you guys how to breathe under 6 breaths per minute. So what you're going to do is you're going to utilize the circular 3 breathing. So essentially what this is you're going to inhale for 3 seconds. It's a nice slow inhale, not a quick inhale. You're going to hold your breath for 3 seconds, and that's where all the magic occurs, because most of us breathe like this. I want you to now consider a relaxing breath as a circle with a hold, and you're going to exhale for 3 seconds. And so what I'm going to do is I'm going to walk you through the first cadence, and then I'm going to have you do it on your own. So each breath should be 9 seconds long, right? And 9 times 6 is 54. Yeah. And so we're going to make sure that you're breathing under 6 breaths per minute. Okay, so I'm going to walk you through the first one, and then you guys are going to count each breath and see how you do. I'm going to pull out my clock again to time you guys. Okay, and I want you to sit comfortably in your chair. Again, I want you to close your eyes if you feel comfortable, and listen to me for the first cadence, and then take over in your own head, okay? So I want you to inhale, 2, 3, hold, 2, 3, out, 2, 3. Go ahead. Okay, stop. Did most of you get below 6 breaths per minute? Pretty cool, huh? So in order for us to take care of our patients, it's highly important for us to take care of ourselves. And so I would strongly recommend that you learn to shut down that sympathetic nervous system response. You do it 1 minute in the morning and 1 minute in the afternoon, 1 minute in the evening, and you've really set yourself up for some great mental health. And so now you have one of my tricks of the trade. And so what I would like to end with here are some of our outcomes at the Mellon Center. We did 2 studies recently, so I want to make sure that you guys recognize that this really works. And so this is a study which we were just looking at changes in mood, and we did a retrospective medical review of 505 patients that had seen us in health psychology from 2010 to 2015. We had some exclusions. We did some cool statistics that one of my fellows was really into, and this is what we found. We found that individuals who did at least 3 sessions of behavioral medicine had decreases in their PHQ-9, and you can see that there were even further decreases after 10 sessions. We saw the same thing for their GAD-7, and their GAD is their anxiety disorder scale. And so as a result, we found statistically significant reduction in both anxiety and depression between the first and the last session who participated in at least 3 sessions. We know that behavioral medicine is very important for a person's overall well-being. We also looked at what determines who receives treatment. And so we looked at the same population, these 505 patients, and we did a stepwise multivariable logistical regression. And what we found were that their PHQ-9 score, so maybe that's because at Mellon Center we automatically send our patients that have a moderate level of depression to us. So their PHQ-9 score predicts receiving treatment. Their marital status, meaning that if they're single, predicts that they will receive treatment, and their course of MS. So relapsing, remitting MS seem to send more people to our office as significant predictors of people who received services. So this was just important for me to share with you so that you can see some of the really wonderful work that we're doing at Mellon Center. In summary, as we conclude, I want you to remember the parable of the blind men and the elephant, and that all specialties work together to understand the entire patient, including the high prevalence of the mental health disorders. So the mind and the body are so closely tied. Hopefully you've now noticed that by way of just remembering what it tastes like to have a lemon in your mouth. Treating the mental health issues saves the medical team's time, aggravation, and the healthcare system money. And it's incredibly important to do the outcomes research so that we can share with you that this actually works. And I really thank you for inviting me today. It is such a privilege to be able to talk about something that's so important to me. I am from Cleveland, Ohio, and in Cleveland, Ohio, we have a basketball player on the Cavs team, Kevin Love, who has recently made a statement about his own mental health, and it's about normalizing mental health. And so I hope that just by having this conversation today, you guys are able to take 1 to 2 things away from here that might be important for your practice, but recognize that we need to do a better job of normalizing and not stigmatizing mental health. Thank you so much.